Module 8, Gastrointestinal. This recording will cover Chapter 58, Coordinating Care for Patients with Intestinal Disorders. Here we have abdominal trauma. So, common abdominal trauma examples are liver laceration, ruptured spleen, mesenteric artery tears, diaphragm rupture, urinary bladder rupture, great vessel tears, renal or pancreas injury, stomach or intestinal rupture. So abdominal trauma can happen in a lot of ways. It can be gunshot wound, it could be stabbing, it could be a car accident, it could be a fight. So out of all of those things, the most common organs that are injured are the spleen and liver. Okay, so we can have blunt or penetrating. Blunt is when the skin is intact. Penetrating is when something actually pierces the skin. So the concerns that we have the most are going to be bleeding, internal bleeding, peritonitis. So that's when something enters the body that's not sterile. So maybe you pierced an intestine or the stomach, some other hollow organ, and all of its contents spill into our peritoneal cavity and causes infection. And then also abdominal compartment syndrome. So that's, say for example, you have something bleeding inside of your abdomen and it starts to push and press on all the organs and tissues around it and the vessels. So things can become obstructed and it leads to compartment syndrome. So manifestations of abdominal trauma, classic of course, they're going to have pain. So guarding and splinting of the abdomen. That means like you're kind of hunched over, hugging your abdomen. The abdomen will be hard and distended. Okay, they like to refer to this on TV shows and movies when they come into the emergency room. Patient has distended abdomen, hard. Okay, they're bleeding. They're saying they're bleeding inside. Decreased or absent bowel sounds. Okay, so that means you have to do a very good focused abdominal assessment. Okay, you always have to listen to the bowel sounds. There may be some abrasions, there could be bruising or discoloration of the skin. This leads us to colons or gray Turner sign. That's going to be on the next slide. Abdominal pain, they can have bloody vomit or blood in their urine, and signs of hypovolemic shock. So with bleeding inside, you're going to be hypovolemic. You're going to be hypotensive. So that's why vital signs, so very important. Checking that blood pressure to see if they're hypotensive and tachycardic. That means they're losing fluid, they're losing volume somewhere. This picture here shows a patient who was in a car accident. This red line is the seat belt. So looks like they were wearing their seat belt, but it was a really hard impact. So they could potentially have some abdominal trauma inside there. So this is Cullen sign and Gray Turner sign. Gray Turner sign is on the flanks, like this picture here on the left. You see there's all this bruising here and there's bruising on the other flank also. Cullen sign is around the umbilicus here. So, and this means that there is some internal hemorrhaging, some internal bleeding. Diagnostics, we're going to do our CBC. We can check the urine. ABGs, our bleeding times, electrolytes, pretty much a basic lab panel. A fast exam is a focused abdominal sonography, which is a diagnostic tool during a trauma, so a fast exam. And then we have diagnostic peritoneal lavage. That's where they insert a catheter in the side where they feel that there's some hemorrhaging or bulging, and they'll put a catheter in to kind of drain to see what that fluid looks like and possibly clean it out if necessary. So management, abdominal trauma, they're going to need a large bore IV access because they're going to need fluid resuscitation. We're going to monitor for changes in their condition, the need for surgery. If the patient has an object impaled, we're not going to remove it. That's done in surgery. They'll likely need an exploratory laparotomy, a surgery to kind of look around if they're not able to really see what's going on in there with imaging. Some complications that can happen, hemorrhagic shock, peritonitis, acute respiratory distress syndrome or ARDS, or DIC, which is disseminated intravascular coagulation. which you'll talk about more in Med-Surg 3. Okay, so we're done with abdominal trauma. We're moving on to Irritable Bowel Syndrome, or IBS. Not to be confused with IBD, which we talk about next. Okay, so Irritable Bowel Syndrome. Whenever you hear the word syndrome, that's usually a group of signs and symptoms that, when together, we call it something. So it's not always a definitive diagnosis, it's a syndrome. So the pathology of this is unknown, and what it is abdominal pain and altered bowel habits for which no other cause can be found. So pretty much you have some kind of GI issue, but they can't really find out what's causing it. One example of this would be if whenever you get stressed out, you have diarrhea, or you have a test in the morning and then you have diarrhea before the test, and then you have diarrhea after the test. It's kind of like irritable bowel syndrome. You can kind of predict it, and there's not really a physiological explanation for it. So manifestations include, it could be diarrhea or constipation. Okay, so it's kind of just GI in general. So diarrhea, constipation, flatus, abdominal pain. You could experience nausea, mucus in the stool, sensation of incomplete evacuation, meaning that you had a bowel movement, but you think there's still more, but nothing comes out. Some non-GI symptoms could be fatigue, headache, or sleep problems. Again, it's different for each person. That's why it's a syndrome. So the diagnosis is based solely on their symptoms or subjective reports. Rome 4 criteria is used. It's here. So this is the Bristol stool chart. If you have recurrent pain more than once per day per week in the last 3 months associated with more than 2 of the following, then you may be diagnosed with IBS. So you can kind of read through this and get a history. You don't need to know the exact criteria or anything. So we're going to get a good health history, family history, drug history, diet history. Is this interfering with their daily life? That will kind of determine how aggressive the management will be. And then we also want to rule out other things, that it could be some other disease or conditions. So there's no single effective therapy. We just kind of have to do things on a trial basis. Psychological support, especially if the patient is saying they're stressed out or they have anxiety or they're depressed, something like that, then we should address that for sure. Dietary changes. So gluten is known to be one of those triggers for GI problems. So oftentimes the first step would be to remove gluten from the diet, or to follow a FODMAP diet. FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So this map here on the right shows examples of a FODMAP, things that you should eat and things that you should avoid. These patients can also be given medications to help regulate stool and reduce pain, depending on what their problem is, whether it's diarrhea or constipation. And then opioid agonists, antispasmodics, antidepressants, antidiarrheals, or laxatives may be appropriate for this patient. Teaching would be to, hopefully they know what their trigger is so that they can avoid that. Keeping a food diary, consume regular meals and drink adequate water, encourage exercise, and stop smoking because smoking is bad. So now we're talking about inflammatory bowel disease. Okay, and this is not syndrome, this is disease. So you see the little umbrella here. That means that this is an umbrella term, and this refers to both Crohn's disease and ulcerative colitis. So both Crohn's disease and ulcerative colitis are inflammatory conditions. Okay, one more time. Crohn's and ulcerative colitis are inflammatory conditions. Both of them are inflammatory conditions. So this is inflammatory bowel disease. So our bowels, both our small bowel and our large bowel, are inflamed. This is chronic inflammation of the GI tract, and it's going to be characterized by periods of remission and periods of exacerbation. So it'll get a little better, and then it'll get worse. A little better, then it'll get worse. So the exact cause isn't unknown. It could be autoimmune, environmental factors, sometimes related to medications, and could be a genetic link. So what basically is happening is that there's an inappropriate response to in the intestinal tract, causing inflammation. So for some reason, the intestines are overreacting and it's causing all of this inflammation that's leading to destruction of our own healthy tissue. So here we have ulcerative colitis and Crohn's disease. So very important you know the difference. So ulcerative colitis. So colitis is referring to the colon. So ulcerative colitis only affects the colon. It's only found in the large intestine. And ulcerative, that means there's ulcers. So ulcerative colitis are ulcers in the colon. Crohn's disease can happen anywhere in the GI tract from the mouth to the anus. That's a huge difference from ulcerative colitis. Anywhere from the mouth to the anus. And here's a picture. So ulcerative colitis is the first one here. And it always starts in the rectum and it moves its way up the colon, okay? Versus Crohn's disease, where it can start anywhere, not even in, it could start in the mouth, in the esophagus, it can start in the small intestine, and it's not continuous. So there's patches of healthy tissue and then they have inflammation, healthy and then inflammation. Okay, so let's go a little bit deeper into Crohn's disease. So you see this picture here, just like I mentioned, there are these normal tissue in between areas of inflammation, okay, and it can be from the mouth all the way down to the anus. So manifestations, there's going to be diarrhea, it's going to cause cramping, there's going to be weight loss, abdominal pain, steatorrhea, which is fatty stools, fever, fatigue, and they may experience some rectal bleeding. So when you have inflammation in any part of the body, but right now we're talking about our bowels, it interrupts the normal functioning of the organ. So here we gain a lot of our electrolytes here, a lot of our fluid, and that's when there's inflammation, it's not going to be able to do that how it should. So we're going to have issues related to that. So keep that in mind. Crohn's disease is it can lead to strictures in the bowel because of all that chronic repeated inflammation. The bowel just kind of narrows and that can lead to a bowel obstruction. There can also, leaks can also develop, abscesses in the peritoneal cavity, and fistulas are also common in Crohn's disease. So fistulas are where there is an opening in the organ and the little tract pathway leads to another organ. Okay, so Crohn's disease is prone to strictures and fistulas. Then here we have ulcerative colitis. So ulcerative colitis only involves the colon. It starts in the rectum and spreads to the cecum, which is the other end of our colon. So there is a lot of diarrhea and electrolyte loss because, like I mentioned before, the colon just can't do its job through inflamed tissue. So if a patient has ulcerative colitis very, very bad, because it starts down here and it starts, you know, just a couple inches, but it slowly will make its way until it covers the entire colon. So if you have a patient that has severe ulcerative colitis and it's covering the majority of their colon, that means the colon isn't able to absorb fluid or electrolytes. So it's that's bad. Okay, protein is lost in the stool with these patients. Okay, clinical manifestations. So they're going to have diarrhea, but their diarrhea is going to be very, very bloody, okay, because they have bleeding ulcers all throughout their colon. So bloody diarrhea, weight loss, abdominal pain, fever, and fatigue. So with these patients, you definitely want to keep an eye on their hemoglobin and hematocrit because it can be decreased. So complications from both Crohn's and ulcerative colitis include hemorrhage. Strictures can also happen with ulcerative colitis, but again, like I mentioned, it's more common with Crohn's. Perforation, okay, again, it can lead to that peritonitis, which is deadly. Perineal abscesses. Fistulas, which is most common in Crohn's. An example of that would be a little path made from the bowel to the bladder. So that patient will actually be urinating urine and fecal matter through the urethra. These patients are prone to C. diff infections, and they can also experience a colonic dilation, which is called toxic megacolon which is pictured here. So this is an extreme case. This is colon right here, and you can see how huge it is. This is rare, and it's widening of that large intestine that develops actually within a few days. So all of that bowel would need to be cut off. It's rare, and the patient can die from it, obviously, but I just wanted you to see a picture of that. Okay, and then anytime you have recurrent inflammation in any part of the body, because those cells die and regenerate, it leaves it open for mutations, so cancer. So patients with Crohn's and ulcerative colitis are at high risk for colorectal cancer. So diagnostic-wise, we're going to get a history and physical. We're going to do lots of labs. So CBC to check for anemia, perforation, electrolytes, albumin related to nutrition, urethral sedimentation rate, which is ESR, and C-reactive protein, CRP, and WBC to look for inflammation. We're going to check the stool. We can do all of these studies here, colonoscopy. So the goals of IBD is to rest the bowel, to control that inflammation and or infection, to correct the malnutrition, to relieve the symptoms, and to improve their quality of life. So they may need supplemental fluids, electrolytes. They should rest, and they need to take their medications. So for IBD, there's a step-up approach level and a step-down approach level. You don't need to know this for the Med-Surg exam. I just wanted you to kind of get an overview of this. So the step-up, step-down approach is referring to this pyramid. So depending on the patient, depending on what they have, the symptoms, and what they present with, and how much it's interfering with their life, they may choose the step-up approach, meaning that you're going to start at this bottom level, which is the 5 ASA drugs and antibiotics, and then they move up to steroids, and then they move up to immunosuppressants, biologic therapy, and then they end with surgery. The top-down approach means that you're starting with surgery and then you work your way down those medications and approaches. So this is from your textbook. These are medications used to treat IBD. You can see here. Now these 5 aminosalicylates listed here, I think they're very interesting, so I included this. Okay, so say you have your colon here, and you see these are color-coded. So wherever the problem is of the inflammation, so say you have inflammation in this green area here, which is the sigmoid colon, rectum/sigmoid colon area. So you would want a medication that is in the route of a foam, okay? Or maybe your issues are here, the inflammation in the ascending colon, transverse colon, then an orally given medication maybe would work best for that. If the patient has inflammation here in the descending colon, then an enema may be appropriate. So for ulcerative colitis, surgery can actually help the patient if it's severe enough and if it's causing, a lot of issues. Because colitis, ulcerative colitis starts in the rectum and works its way up, you can potentially just remove that part of the colon and they would be cured. So if it's severe enough, especially for patients where the ulcerative colitis has taken over the whole colon, then they may want to have one of these types of surgery. We have an IPAA, which is a total proctocolectomy with ileopouch/anal anastomosis. They get very creative, and these work for people. So you can kind of look at the picture and see what they do. The patient could end up with an ileostomy, which is removal of the whole colon and having an ostomy at the small intestine. So for Crohn's disease, surgery is usually done for complications because remember, Crohn's disease, they have these patches of good tissue and then bad, good, bad, good, bad. So you can't cut out all the bad pieces and connect all the good pieces. So these patients only get surgery when there's some other complication. And typically it's done when there is stricture. So remember, with Crohn's disease, stricture is more common, where there has been so much inflammation there that the intestine just kind of gets really, really narrow, and it can lead to bowel obstruction. So there's 2 different things that they can do. They can do this approach here. Okay, they cut it, and here is a real life example of that. or they can literally just cut out the piece and then sew it up together. So these patients commonly have nutritional deficiency because maybe they're they have nausea and vomiting and diarrhea and they don't want to eat, or maybe they've had blood loss, or maybe they just can't absorb the nutrients because of all that inflammation. Some other medications that they can take can also contribute to nutritional problems. So you always want to keep nutrition in mind with IBD. During an acute exacerbation of IBD, they may not tolerate their regular diet, so they may need, supplemental liquid feedings that are high in calories and nutrients, are easily absorbed. And then once they can tolerate it, you can introduce their regular foods. So the goals of management, as a recap, is to provide adequate nutrition without worsening their symptoms, correct or prevent the malnutrition, replace the fluid and electrolyte losses, and prevent weight loss. And then we have our education here, frequent small meals, have the person engage in mealtime with family to encourage them to eat. They should rest, know what to report to the doctor, and perianal skincare. Don't forget about the perianal skincare, because if a patient has lots of diarrhea, lots of bloody diarrhea, then their skin can be compromised. And then gerontologic considerations for IBD. Diagnosis can be more challenging in the older adult, so we want to make sure we're doing a really good assessment. The medications we give the older adult, there's increased risk of adverse events, hospitalization, higher risk for infection and cancer, higher risk for getting anemia, malnourished, and volume depletion. And if they do have that diarrhea, frequent diarrhea, getting to the bathroom might be an issue for them. Moving on to celiac disease. So celiac disease is an autoimmune disease. It's an autoimmune reaction to gluten that causes inflammation in our small intestine. So here in this picture on the left side is the normal lining of our intestine. You see all of this villus here, and all of this helps to absorb our food and our nutrients in the lining of our intestine. In celiac disease, all of those villus atrophy, they die, and it's gone. So that is the main problem. So gluten is in wheat, barley, and rye. And a lot of times people who have celiac disease also have other autoimmune disorders like rheumatoid arthritis, type 1 diabetes, or thyroid disease. So if you have a patient that comes in and they are a type 1 diabetic and they've saying, I've been having some GI upset when I eat certain foods, then you may want to investigate to see if they have celiac disease. So 3 causative factors: genetic predisposition, gluten ingestion, and an immune-mediated response. So all 3 of those together, boom, you have celiac disease. So the classic signs are foul-smelling diarrhea, abdominal pain, flatulence or gas, abdominal distension, and malnutrition. These atypical and other signs could happen, but those classic signs are what you're going to see the most. Diagnostic, really simple. You're going to screen for those antibodies. It's an autoimmune disease, so we can draw blood and see if they have those antibodies circulating. History and physical, we're going to check for vitamin deficiencies. They can take a biopsy of the cells in the small intestine to further do genotyping to see, confirm that autoimmune disease. So here, education is going to be big because this is something that's not going to go away. They're going to have to live and deal with this for the rest of their life. So we want to get a dietitian on board, educate about the disease, how it happened, why it happens, that this is lifelong. They're going to have to stay away from gluten. They're going to have to recognize malnutrition. We can provide resources on support groups and teaching. So they should learn how to read the labels. That's really important on food products. They should be familiar on on the common sources of gluten, like pictured here: yeast, barley, rye, wheat, wheat starch, grains. They should use a dishwasher to be safe, to make sure that there is no gluten residue. Some patients are very, very sensitive to gluten, and even just a dish that wasn't washed appropriately and has gluten can cause a flare-up. Next is diverticulosis and diverticulitis. So we need to know what a diverticula is. So a diverticula is this little sac or pouch on the mucosa of the colon. So you can see here on the right side of the picture, there's these little pouches that extend out from the interior of the colon out. And diverticulosis is just the presence of these little sacs. Diverticulitis is when these sacs become inflamed and infected. Okay, so that's the difference. So again, diverticulosis refers to multiple non-inflamed diverticula. Diverticulitis is one or more inflamed diverticula. Okay, so one is not inflamed, one is inflamed. Complications that can happen are perforation, so a hole, abscess, so a fluid-filled sac with pus, fistula, and bleeding. So the cause of this is both genetic and environmental. The main factors are related to constipation and the lack of dietary fiber. Obesity, inactivity, smoking, excess alcohol use, and NSAID is all thought to also contribute to the formation of these little pouches, these little sacs, protrusions, whatever you want to call them. Again, pouch-like sac, okay, in the mucosa of the intestine. So these little pouch-like sacs here are holes, they're vacant. So if the patient eats seeds, especially like food that can get trapped there, it can lead to diverticulitis. So again, I'm saying it again, seeds can often lead to diverticulitis because they get trapped in those little pouches, and it can lead to inflammation and infection. So for a patient that has diverticulosis, it's usually asymptomatic. If they do have signs, they'll have some abdominal pain, floating, maybe a change in bowel habits. But if it becomes inflamed and they develop infection, then they're definitely going to have some pain, especially in the left lower quadrant, abdominal distension. They could have increased or decreased bowel sounds, nausea, vomiting, and then systemic signs of infection. So fever, high white blood cell count, and you may be able to even palpate a mass in the abdomen. In the older adult, they may not have a fever, they may have a normal white blood cell count, but they may have some abdominal tenderness. And again, complication, erosion of the bowel wall that leads to perforation, abscess, peritonitis, and bleeding. So diagnostic studies, we can do a colonoscopy or a sigmoidoscopy. So they can stick the camera through here, through the anus, and check out, and they'll know right away if there is a presence of those diverticula pouches. CT scan with oral contrast will light it up like you see here in this bottom picture. We want to check for blood in the stool, CBC, barium enema, blood cultures, x-rays. So management. The best way to manage this is to prevent it altogether. So when you're trying to prevent this, you want the high fiber, decreased fat and red meat, physical activity, and hydration. So if you're already in an episode of diverticulitis, okay, so say you have diverticulosis, you want to prevent an exacerbation of that by maintaining high fiber. But when you have diverticulitis, so now it's inflamed, it's angry, it's infected, we don't want high fiber because we don't want any residue. We want things that are going to just be digested and excreted out of the body, okay, because we're trying to kind of be calm in our bowels. So clear liquids, bed rest, they may even need some pain management. So surgery would be done if a complication happens, like perforation, obstruction, abscess, and so on. So patient education, they should know why this is happening and what they can do. High fiber, fluids, avoid increased intra-abdominal pressure like straining, bending, lifting, reduce weight if necessary, and to complete those antibiotics. So next we're going to talk about appendicitis. So the appendix, which you can see here in this picture, is a small hollow appendage that extends off the cecum. The cecum is where the small intestine meets the large intestine. And we know that it's made of lymphatic tissue, but we really don't know the purpose of the appendix. So appendicitis usually happens as a result of a fecalith, which is kind of like a fecal matter that's been rolling around and condensed kind of like into a stone-like ball, fecalith. So either a fecalith or another foreign body blocks the opening. And then when it blocks it, it leads to inflammation, then it leads to infection. So some other things that are less common that could cause it would be maybe like a cancerous tumor, or maybe the appendix twists and kinks on itself and then it causes, the same outcome. Okay, so clinical manifestations. At first, the patient will have a dull periumbilical pain, loss of appetite, nausea, vomiting. They'll have pain, persistent pain in the right-left quadrant at McBurney's point. Right lower quadrant at McBurney's point. Fever, tenderness at the site, rigidity, rebound tenderness. That's when you press down, there's no pain. When you let go, that's when the patient has pain. There'll be increased pain with cough and sneeze and deep breathing. And if the patient presents this way and then all of a sudden all of the pain disappears, that may indicate that the appendix actually ruptured. In the older adult, they'll have less pain, they might have a slight fever, and they'll experience pain in the right iliac fossa area. So diagnostics, a CT scan or ultrasound or MRI can be done, and surgery will be done to avoid rupture, because if it ruptures, that's going to leave an opening in the intestine where fecal matter can come leak out, and that will lead to peritonitis and ultimately death. Fluid and antibiotics are the treatment. So here you can see in this picture, this is a little image of an upset appendix. So it's turning black, compromised blood supply, that's going to be a problem. So this slide shows you where McBurney's point is. So this is going to be where your appendix is located. First, you're going to divide the abdomen into the 4 quadrants using the umbilicus as your landmark. Then you're going to go right between the umbilicus, so the belly button right here, and a third of the way between the anterior superior iliac spine, which is right here. So about a third of the way, which ends up being right here. And that is where your appendix would lie inside of you. So if the patient is experiencing a lot of pain right at that point, you can probably assume it's the appendix. And here's a real life picture of an appendix being removed, and you can see how big it is here. It's red, it is enlarged. That is not a happy appendix. And then here, down here, you can see the fecalith. So this is like a feces stone that lodged itself in the opening of the appendix, which is what caused the appendicitis. So your role, preoperative, you're going to give IV fluids and pain medication. You want to prevent complications, so they should be kept NPO. They shouldn't be eating anything if they have appendicitis. We're going to monitor vital signs. They might experience some nausea, vomiting, so we can give some antiemetic medication. Post-operative is going to be real general, very similar to any laparotomy, any abdominal laparotomy. Turn, cough, deep breathe, and septic spirometer. Early ambulation is always highly encouraged. Advanced diet is tolerated. And if that appendix did rupture, then antibiotics should also be given post-operatively. Next is colorectal cancer, CRC for short. So this type of cancer is more common in men than women, and the risk for CRC increases with age. So about 90% of the new cases of colorectal cancer are detected in people over the age of 50. So clinical manifestations. Most common is going to be iron deficiency anemia, rectal bleeding, abdominal pain, and change in bowel habits. So really important that patients are reporting these changes so that this cancer can be treated early. So other clinical manifestations, sometimes there's none, it's asymptomatic. They may feel tired, they may have weight loss, Risk factors include family history. If you've had inflammatory bowel disease, IBD, that includes Crohn's or ulcerative colitis for 10 years or more. Physical inactivity, obesity, and a diet high in red meat. All of those things put you at higher risk for colorectal cancer. So I included this slide because I thought it was very interesting. It's not from your textbook, but here's a picture of our colon, and the ascending colon here and the transverse colon. Women are more likely to be diagnosed with cancer in this area versus the descending colon, sigmoid colon, rectum, and anus is more likely to be diagnosed in men. So I thought that was very interesting. Depending on the location of the cancer in the colon, the patient can exhibit different signs and symptoms. So this is just an example of that. So for example, if there is tumor or cancer in the transverse colon, patient will complain of pain, more likely for obstruction, change in bowel habits, and anemia. Versus the rectum, signs and symptoms, change in bowel habits, blood in stool, and rectal discomfort. So colorectal cancer usually starts from a polyp on the inner lining of the rectum, and it grows for like 10 to 20 years before it actually turns into cancer. It will invade the colon or the rectum, the lymph nodes, and the vessels around that, and it just spreads. But what also makes metastasis kind of easy for this type of cancer is that our intestines are not only our colon, but our small intestines. When we eat, the food, the nutrients gets absorbed through the small intestine, the large intestine, and it goes into these vessels that empty into the liver for processing. So it's very common that metastasis will go to the liver right away because the blood supply there, it's directly connected to our bowels. And then the second picture here is staging. So we know about staging. The deeper the cancer, the more severe, and then it will eventually hitch a ride into our vessels and into our lymphatic system. Diagnosing this, if the patient already has history, then they should be screened earlier than someone with an average risk. The gold standard is colonoscopy, so they should follow that schedule. And there's some other exams that are sometimes done, like a flexible sigmoidoscopy or a double contrast barium enema or a CT scan. But typically you're going to see a colonoscopy done. So treatment of colorectal cancer, again, it's cancer, so we want to do surgery to remove it if possible. Want to check to make sure it hasn't spread. And then also post-operatively making sure they don't have complications and they don't have a return of the cancer. So if they're having a colonoscopy and there's a polyp that's suspected, then they'll just remove that in situ. So situ means that it's right there in that tissue in the moment, situ. They will take out a margin of the polyp, so they'll take out some healthy tissue too, just to make sure they got it all. So sometimes it can just be done during a colonoscopy, and they don't necessarily need, open surgery. But sometimes they do need to be resected where they actually remove some of the intestine. So education-wise, healthy weight, active, limit alcohol, don't smoke, eat a good diet, get screened for CRC, especially if you are already high risk for colorectal cancer, and then also educate your patient on the bowel prep for that colonoscopy that they need to have. So acute care. They may need to have a bowel resection. That means that they're just removing a piece of the bowel and then connecting the bowel together. They may end up with an ostomy. It could be any of these here pictured, transverse, ascending. It just depends on where the cancer was and how much of the bowel they had to remove. If the surgery was pretty extensive, they may have a bowel after surgery. They may require wound care, ostomy care, and teaching, so keep that in mind. Ambulatory care, so once they go home, psychological support if they have an ostomy and it's cancer, so we want to make sure they have the support and they come back. Next are hernias. So hernias are protrusion of intestine through an opening or weakened area in the cavity wall. So you can see that pictured here. So there's two main types, reducible and irreducible. So the reducible types, you can push it back into the abdominal cavity, no problem. The irreducible or incarcerated type, you can't push them back in, and they can end up being strangulated, like this picture. So if they become strangulated, they can potentially lose their blood supply, become ischemic, turn black and die, and then cause infection. So we are trying to avoid that. So risk factors on getting a hernia include obesity, smoking, excessive wound tension, malnutrition, pregnancy, and medications. So some causes could include straining, lifting heavy objects, muscle strain, weight gain, and even a chronic cough can lead to a hernia. These are the types of hernias based on location. So ventral, umbilical, inguinal, and femoral. So signs of a hernia: pain. You may be able to see a bulge or visible swelling. And if it becomes strangulated, they'll have severe pain, vomiting, cramping, abdominal pain, and distension. So managing this is going to be based on a history and physical. We're going to get some imaging. Treatment sometimes is just a watch and see if it gets worse, especially if the patient's older. But if it is strangulated or large or causing other issues, then they can do surgery. It's usually laparoscopic, so it's not open. They just make a few holes, they go in and they fix it. Post-operatively, you want to monitor their I's and O's. For males with hernias, especially in the inguinal, femoral area, it can cause scrotal edema. So you want to place the scrotum on ice and elevate. You want to encourage patients to cough and deep breathe, and when they do that, they should use a pillow to splint to provide support on the abdominal incision. Try not to cough or sneeze with an open mouth, no heavy lifting, pain management, and clear liquid diet, and advance as tolerated. So even though surgery is done and the hernia is repaired, it can still come back again because maybe the patient just has issues with the abdominal wall and it becomes weak and it kind of like opens. And there's always going to be a chance that that intestine can become strangulated and it just can keep happening again. Next are hemorrhoids. So hemorrhoids are dilated hemorrhoidal veins. So they're just veins that are engorged with blood. They can be internal or external. And it happens when increased anal pressure and weakened connective tissue results in downward displacement. That is the technical definition. So risk factors that may lead to hemorrhoids are pregnancy, constipation, straining, diarrhea, heavy lifting, prolonged standing, sitting, obesity, and ascites. So clinical manifestations include bleeding with defecation, especially when they're internal, pain, prolapse. You'll see a protruding mass if that happens. So you can see in this picture, these are both hemorrhoids, and the one on the right is mild, on the two, very large. On the first picture, it's very large. If you have external hemorrhoids, they might be reddish to blue in color. They may itch, they may burn, they may become edematous. If you have a thrombosed hemorrhoid, because remember we're talking about vessels, they may also be bluish purple, palpable, inflamed, and they'll bleed with defecation. So diagnosis is made by either just doing an examination looking or a digital rectal exam, or they can do a sigmoidoscopy with a scope if they're internal. Treatments, we want to avoid constipation, that straining, that bearing down. So a high fiber diet, increase fluid intake to prevent, again, constipation and reduce straining. Ointments, creams, suppositories, there's all kinds of medications on the market. There's some over-the-counter meds that they can do to help with that inflammation. There's surgery to remove them if necessary. So some complications that can arise from hemorrhoids are infection, pain, urinary retention, fecal impaction, damage to the sphincter, bleeding, and abscess formation. So what you need to know if they do end up having a procedure to remove the hemorrhoids, you want to make sure that you give them some pain medication before they have their first bowel movement after surgery. because it can be a little painful. Remember, they just had surgery in that area. It might be a mind over matter thing in their head. They don't want pain, so they're going to hold it in, but that's not good. So they may need some stool softener and pain medication. They'll have some local anesthetics, possibly some corticosteroids for inflammation. They can use ice packs, a sitz bath to help with circulation, soothing, remove debris, laxatives, and heat can also be applied. So it can be from cold to heat. Teaching, that is a high risk for infection area, so we want to make sure we keep things as clean and dry as we possibly can. Although we want them to have a bowel movement, we don't want them to take stimulant laxatives. So that can irritate the bowel. We don't want stimulant laxatives. We can do non-pharmacological methods of pain. That the sitz bath is an example. And then we want to make sure they know when to call the doctor. So signs and symptoms of infection, and if you have that word worsening, so worsening pain, worsening edema, stuff like that. And that concludes this chapter.